Okay. Now let's have another discussion about today's discussion about various types of drugs in the management of minerals of the bones. Minerals of the bones is the main topic today for discussion for this class, and the main areas of discussion is number one, mechanism of absorption, mode of action, and the role of minerals in the body. Various minerals of the body will discuss various way they work. Number two, diagnosis and symptoms of bones, mineral homeostasis and related disorders. Look at a few of them. Then you look at drugs for bone disorders with mode of action at receptor level and side effect. And then you receive therapeutic for bone disorders. A few of them. Now, let us start first of all with the one mineral, and the most mineral when it comes to bones is a mineral called calcium. Now, calcium is a very important element in our body in terms of muscle contraction. Again, it is very vital for fusion and release of stored vesicles in the body, in the cell organelles, and also it is very important in the intracellular because it acts as a critical messenger in the intracellular transportation and the communication from one cell organelle within the cytoplasm. The other important of calcium is it promotes blood coagulation. It promotes blood coagulation. The other one is that it forms formation and continuous remodeling of the skeleton. And this is the reason why you have this topic. The major reason for this topic is about the skeleton in terms of bone remodeling. The other important factor about calcium is an important structure in protein in bone matrix. In adult men, 1.3 grams, 1.3 1,300 grams, and in women, 1,000 grams in women is amount of calcium needed in a daily. So 99% of our teeth, 99% of our bone is made up of calcium. So in a normal serum, when you have to check serum concentration in the body, the normal calcium concentration is 8.5 to 10.4 milligrams per deciliter. In this case now, it appears in various forms in the serum, and it can appear as ionized. And 50% of the iron of the calcium in the body is ionized, whereas 40% is bound to the protein. And this one most commonly is albumin, which accounts for 90% of this one. And of the albumin is made of calcium. Then we have the other complexes of calcium in the body. Now, calcium is very important in the bone in terms of bone resorption and also bone formation. It's very important and very labile. It is exchanged in the interstitial fluid. So it is exchanged in the interstitial fluid that is on the tissues. And then this exchange is modulated by, that it means it is this exchange in the interstitial fluid is regulated by hormones, and you'll see some of these hormones. It is also regulated by vitamins, an example, vitamin D, and drugs, and an example of these drugs is like thiazide drugs, and also phenytoin and corticosteroids. Corticosteroids and other factors directly interfere with this one and influence the bone in the interstitial areas. So diet has a low in calcium, and we need to compensate it. So this is why some children are given vitamin calcium supplement, and this one is partly activated by alpha D3 vitamin. So drug such as glucocorticoids and phenytoin depresses calcium intestinal absorption, calcium transport. So When you're giving calcium supplement in patient, especially children, you have to be very careful when you're giving corticosteroids and pentatoid concurrently because there will be a drug interaction. So calcium absorption, 75% of the calcium from the milk and dairy products, the 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 amount of the amount of the amount of calcium in the body, that is 1,300 milligrams in adolescents, and in adult they require 1,000 milligrams per day. That means adolescents, because they are growing and they're making bones, they need a more amount of calcium to make their bones. So after the age of 50, the intake is the hard activity intake is around 1,200 milligrams per day. That means at this point now, the osteoporosis has started setting in. So calcium enters the body through the intestines, in the villi, and active vitamin D3 depends transport on the proximal duodenum. So active vitamin D dependent transport occurs in the proximal duodenum. So that means calcium and absorption is dependent of vitamin D, and it takes place in the proximal tuberous. So you can see that intestine, 800 milligrams of intake of calcium, then it has to depend on activated vitamin D3, where around 300 milligrams is absorbed, 150 milligrams is endogenously lost. So let's say you take 800, then 300 absorbed, then you lose around 650 milligrams or in the fecal. Then the one which is absorbed is used in the body, especially the bones, and then the kidney every day filters 900 milligrams of the calcium, and around 850 milligrams is absorbed, where 150 milligrams is excreted out. And this one happens only in a normal person, and this one does not occur in end stage renal failure. It is the other way around. So urinary calcium excretion is about 9 grams of calcium are filtered each day, and there is 98% is reabsorbed in the tubula. The absorption is regulated by parathyroid hormone. It's regulated by parathyroid hormone. In the roof of Henry, and we call them non-selective. We call them non-selective diuretics, which does not spare electrolytes like furosemide, thiazines. They increase excretion of calcium in the roof of energy. So by contrast, thiazine diuretics diminish calcium excretion. So thiazine reduces calcium excretion in our body. So it assists somewhere. So that is all about phosphate, about calcium. The other molecule you have to look at is phosphate. This is also a very important component of our body tissues. It's present in the plasma and intracellular fluids and cells membrane, and the phospholipids important in the cell membrane for the purpose of transport. And you know that even the phospholipids, that is where the arachnoid pathway starts in terms of in terms of modulators of inflammation. So intracellular fluids is also a part of there is also some part of intracellular fluid which contains phosphate, collagen, and also bone tissues. And in our case here, we're interested in bone tissues. So 80% of body phosphorus is in the bone and 15% is in the soft tissue. So phosphorus laws in the body is that they are very important. Phosphorus is very important in energy metabolism. It's a key regulator in terms of enzyme in the ATP and the protein kinase metabolism by phosphorylatable serine, theroine, and the anthroderoxine residues. In simple, this one is an explanation on how hormone interaction controlled by bone minerals homeostasis. How the body maintains mineral homeostasis in our body, and the main player is thyroid hormones, and also parathyroid hormone are the key players in this case. So the one what happens is that if a calcium levels is above a set standard point, the thyroid gland will release calcitonin, and this calcitonin will be bound to the blood and will make the calcium levels come down. And any these calcium levels come down because calcitonin will prevent the calcium in the blood level to go high. So this calcitonin, if the blood level goes down, what will happen is that if the calcium falls below the normal level, the parathyroid hormone comes in. If it goes below normal, the parathyroid comes in, and in this case, the calcium level comes high. So in this case, you can see that the parathyroid and thyroid hormone does opposite way. The main function of the thyroid gland is to release calcitonin, which regulates the calcium level downward. Whereas parathyroid gland produces parathyroid hormone, which its main function is to increase the amount of calcium in the body. Now, the hormonal regulation of calcium and phosphate homeostasis is that the parathyroid hormone plays a big role, and the 125 hydroxyl vitamin, that is calcitriol, is very relevant, which regulates mineral homeostasis by effect on the kidney. This one regulates on the kidney, intestines, and bones. These are the three areas where it takes the place. In the intestine, it is the absorption. In the kidneys, it is absorption in the tuberous. In the intestine, it is absorption from the diet, and in the bone, it is by the cells called osteoclast and osteoblast, which reabsorption and breakdown of cells of the bones to make calcium is what is regulated there. So those are the three areas where this one plays big role. So the parathyroid hormone regulates calcium by affecting bone reabsorption and formation, calcium reabsorption and excretion in the kidneys, and calcitriol synthesis in the GIT after absorption. And remember that the proximal distal in the proximal cecum and duodenum, that is where calcium is reabsorbed and it is activated dependent on vitamin D3 activation. So the parathyroid hormone chemistry is that it's a single polypeptide chain containing of 84 amino acids with a molecular mass of 950 DAR. Biologic activity is associated with binding to the parathyroid hormone receptors, and the signal pathways is CAMP or IP, calcium changed ions. At low level of calcium in the body, parathyroid hormone is secreted so that increases, and this one makes parathyroid. When the calcium is low, the sensors in the parathyroid hormone senses there is low calcium, and this parathyroid is increased, and these ones makes the kidney to reabsorb a lot of calcium, the GIT to reabsorb calcium, and also the bones to be broken down to release the calcium. The hypocalcium induces parathyroid hypertrophy and hyperplasia. So hypocalcium, if there is excessive persistent raw calcium in the body, it is going to cause hypertrophy and hyperplasia. Hypertrophy and hyperplasia of the parathyroid hormone, and this is the parathyroid gland, and this is in terms of a cellular, in terms of cellular composition. So calcium itself appears to regulate primarily gland growth as well as hormone synthesis and excretions. So antinergic receptors agonist and dopamine increases parathyroid cells and AMP levels and increases parathyroid secretions in our body. So what is the effect of parathyroid hormone on our bones? The parathyroid hormone enhances the absorption and thereby increases calcium derived the extracellular fluids. The primary skeletal target cells of parathyroid is the osteoclast because these osteoclasts are the precursor cells to form new bone that is the remodeling unit of the bone. Okay, the remodeling unit of the bone. So vitamin D is another important molecule in terms of bone. Vitamin D is permit efficient absorption of dead calcium. You remember that in the duodenum, you have to depend on activated D3 and D so that there is absorption of calcium in the duodenum. So, and allow full expression of the action of the parathyroid. So, vitamin D is actually a hormone rather than a vitamin. It plays more of a hormone than a vitamin. Synthesized in mammals and under ideal conditions probably is not required in the diet. So the bodies, they synthesize their vitamin on the skin through ultraviolet rays. The receptor for the activated form of vitamin D are explained in many cells: lymphocyte and epidermal cells, hair follicles, adipose tissues, and pancreatic islet in the pancreas, and also muscles and the neurons. So, in the maintenance of bone homeostasis, it involves multiple but coordinated cellular and molecular event levels. The two types of cellular are responsible for bone metabolism are osteoblast and osteoclast. The main functions of the osteoblast is to make new bones, whereas osteoclast is to break down bones for the purpose of release of calcium. In this case, if there is low calcium in the body. So when a patient has a fracture and healing the process is taking place, you see that the body starts having a lot of osteoblast. So in osteoporosis, osteoclasts are increased. So the structure of bone as well as adequate supply of calcium requires a close cooperation between these two main cells. So the bone metabolism relies on complex signals, pathways, and controls a mechanism to achieve proper rate of growth and differentiation. So these control include the action of several hormones, including parathyroid hormone, and you have seen that parathyroid hormone, the main function is to increase the amount of calcium in body. Vitamin D, which is very important for the absorption of GIT, calcium in the diet, and this takes place in the proximal duodenum, and the vitamin D has to be activated. The other ones are acne growth hormones, steroids, and calcitonin. And calcitonin is produced by the thyroid gland. No, where the thyroid gland is a home to parathyroid. So, as well as other bone marrow derivatives, membranes, and also soluble cytokines and growth factors are one of the major factors which influence homeostasis of the bone. So, there's something called bone remodeling, and the bone remodeling is appropriate. The osteoclasts are the one which plays this. Please, this happens more cases where there is things like fracture. Yeah, the ones which plays a big role in this one assists in the position of calcium. So target the cells that are responsible for body building are known as the basic multicellular cells and multicellular unit. And the temporal duration is lifespan of a basic multicellular unit is referred to as the bone remodeling period. So in bone remodeling, the bone, that is the bone metabolism is a lifelong process because of young growing, there is breakdown of tissues in our body. So in this remodeling, there is mature bones is removed from the skeleton, a process which is a process called osteoporosis, and new bone is formed in the body. The process also controls the reshaping and replacement of the bone following injuries like fracture and also micro injuries. In the first year of life, almost 90% of the skeleton is replaced, and in adult remodeling process take about 10% per year. And imbalanced in the regulation of bone remodeling, two sub processes, bone resorption and bone formation, result in many metabolic bone diseases such as osteoporosis. So in osteoporosis, this is a disease is a disease where the skeleton in the bones is getting thin and prone to fractures. In other words, the bone loses calcium and density, and this one happens at the age of 65. About 90% of the women have osteoporosis, and nearly all of them are unaware of their conditions. After the age of 80, up to 70% of the women develop osteoporosis. This is because there is those hormones after menopause. They decrease in the body, and because also they play a big role in bone remodeling. So osteoporosis is a major risk factor for fracture in the spinal and the hip. The decrease in bone density can also lead to bone loss in the jaw and subsequent tooth decay. So overall, 2 million osteoporosis-related fractures occur in the United States annually, with an estimated cost of $17 billion annually. So you can see the key, the burden of osteoporosis in the American economy. So the prevalence of osteoporosis in many may be on the less in the other part of the world due to decrease in the overall routine utilization of hormone replacement therapy for most postmenopausal women. Also, where osteoporosis is less prevalent in men than women, men account for almost 30% of raw bone mass retained, and this is related to fragile fractures. So let us see secondary hormonal regulators of bone minerals or homeostasis. So, calcitonin, which you say that it is secreted by thyroid, and the main function of calcitonin is to reduce to lower the amount of serum calcium in the body. It is activated, it is produced by the thyroid gland when the body realizes that there is excess calcium in the body. So calcitonin lowers calcium and phosphate by action on bone and kidney. We remember that bone is osteoblast and osteoclast, whereas in the kidney it is reabsorption in the tuberous. So glucose corticoids alter bone membranous homeostasis by antagonizing vitamin D stimulation in the intestinal calcium transport by stimulating renal calcium excretion and by blocking bone formation. So you can see how glucocorticoids, you have to be very careful when you are giving them. It antagonizes D, it interferes with the absorption and transportation of calcium. It also stimulates renal to excrete calcium, and also it blocks bone formation. So estrogen, which are hormone of the women, it prevents accelerated bone loss by reducing bone reabsorption action of parathyroid hormone. Increased these calcium hormone level in the body also is a factor. So many increased risk of breast cancer from continuing estrogen also very common. Now, the drugs of osteoporosis are as follows. There is calcitriol, analogs, biphosphates, calcimimetics, cinacalcet, calcitonin, estrogen, calcium, and parathyroid hormone. These are the drugs of osteoporosis. They are the drug of osteoporosis. Now, the first one is calcitriol analog drugs. It is available either orally or also can be given as injection. Intravascular injections, high doses of calcitriol or one of its derivatives predominant use for patient with predominate the patient use with chronic kidney disease and also end stage kidney disease. Because in this case, the kidney is not producing vitamin D. Again, the kidney is not reabsorbing the calcium in the body. So this one is very important in end stage kidney disease. So therapeutic indications for vitamin D, the major therapeutic uses for vitamin D may be divided into 4 categories. The first category is about prophylaxis and the care of nutritional rickets, especially in children. Like the one you can see there, that one has a ball again because of lack of calcium. Also, it is used in treatment of metabolic rickets and osteomalacia, particularly in the setting of chronic renal failure. Again, it is also used in the prevention and the treatment of osteoporosis. Those are the 4 areas where we use vitamin D for prophylaxis and the care of nutrition rickets, metabolic rickets, osteoporosis. Those are areas where we use this vitamin D. So let us see the adverse effect in these cases of therapeutic vitamin D therapeutic. It can cause hypercalcemia with or without hyperphosphatemia. Of course, it may also limit use of dose use effectively of parathyroid excretion. Hypervitaminosis can occur of vitamin D and should be treated by needing to withdraw of the vitamin. And then low calcium diet and addition of corticoids, diuretic is also useful in this type of vitaminosis. You use diuretics to excrete it, you use corticoids, and also use low calcium diet, and also you need to do the drug immediately if you suspect hyper vitaminosis of this vitamin D. So other molecule is what is called phosphorus, and this one is biphosphonates, biphosphonates molecule. There is first generation of biphosphate, and the most molecule in the market is mendronate, glendronate, dendronate, and glendronate. The second generation is amino biphosphonates. An example is arendronate and amidronate, which contains a nitrogen group in the chain, the molecular chain. So it is 10 to 100 times more potent than the first generation compounds of set. So the third generation is we call them lisinoprate and the zonendronate containing nitrogen atom with in heterocyclic ring and are up to 10,000 more potent than first generation agents. So lisinoprate and zonendronate are the best molecule for phosphate supplementation. So let us see how this biphosphate works in the body. Biphosphate in the body mode of action is the concentration at site of active remodeling of the bones. So you will see that where there is at the point where there is a fracture, in the case of a fracture, you will see a lot of these phosphates there because where remodeling is taking place. That is where they are, or where there is growth of the bones incorporated into the bone matrix, analog of pyrophosphates accelerate apoptosis. Apoptosis is a programmed cell death of osteoclasts and reduce their number. Disruption of cytoskeletons of osteoclasts inhibit differentiation of osteoclast precursor and inactivation of osteoclast by disturbing metabolite pathways in lipid synthesis. That is the mode of action of biphosphate. Okay, the mode of action of biphosphate. So how do we use biphosphates? Biphosphates are used in the management of osteoporosis. An example are Residronate are the most effective than castotin. The other is in the management of Paget disease, which is the honeycomb-like bones, and alendronate, isindronate, palmidronate, and isodendronate are cheaper than calcitonin. So in this case, they are used in this. Then also in the management of hypercalcemia of malignancy, the treatment of choice is palmidronate or zolendronate, or you can combine with calcitonin. So by phosphate absorption and excretion and fate. So all very poorly absorbed from the intestines, low by availability of less than 1%, that is alendron, and less than it, 6%. The most one which can have a little bit high is tindronate and tridinolate. So you can see that this drug giving orally, you have to be very careful because there will be a lot of waste. Food detection absorption should be administered with a full glass of water following an overnight fast and at least 30 minutes for breakfast because this one food reduces absorption of this biphosphate. Oral biphosphates have not been used widely in children or adolescents because of uncertainty of long-term effect of biphosphate on the brain skeleton. It is excreted by kidney. Biphosphate are excreted by the kidney. So biphosphates absorption fate and excretion continuation is that permendronate is not available as an oral preparation because it causes gastric irritation. However, with the possible exception of tindronate, all currently available biphosphate have this complication of this complication. So 50% of absorbed drug accumulate in the bone, rest is excreted and changed in the urine. So these biphosphates are contraindicated in esophageal motility disorders and also peptic ulcer diseases and also renal failure diseases. Biphosphates, a side effect is that they are very safe at high doses. Gastric that is, a tendon can cause gastric problem, and then esophageal can be caused by amendronate, and adrenalinate can cause irritation. Irritation is minimum by taking the drug with a glass of water and remaining upright for that minutes. So rarely it can cause osteonecrosis of the jaw. That is, the prevalence is 1 to 100,000. IV doses of Dendronate. Dendronate are used to control bone metastasis, cancer-induced hyperplasia. So the other molecule of concern is calcium mimetics. An example is sinacarcinate. Sinacarcinate blocks parathyroid hormone excretions. A neo is a new class of drugs that activate the calcium sensor receptors. Calcium sensor receptors is widely distributed but has high greater concentration in the parathyroid hormone. So the mechanism of action of these calcium, these sinacarcinates, sinacarcinates, sinacarcinate is that the mechanism of action is that these drugs act as cosmetics by allosteric activation of the calcium sensing receptors in the body. So the calcium sensing receptors on the surface of the chief cells of the parathyroid gland is the principal regulator of parathyroid hormone secretion. So sinacarcinates increases the sensitivity of calcium receptors on the parathyroid cells to reduce parathyroid hormone levels and thus decreases serum calcium levels. So as a receptor, I already block the cosmetics, so this in a carcinate, the native release, and four of calcium levels now interact with the remaining receptors, effectively lowering the duration of activation of feedback on the parathyroid chief cells. So approved for the treatment of secondary hyperparathyroidism in chronic kidney diseases and the treatment of parathyroid carcinomas. That is the time we use these RC mimetics drugs. And an example is sinacasinate. That's an example of these type of drugs which are available in the market. Okay, so calcitonin uh, lowers plasma calcium levels and phosphate contractions, concentration in the patient with the hypercalcemia by decreased bone disruption. Although calcitonin is effective for up to 60 hours in the initial treatment of hypercalcemia, less active after a few days due to receptor downregulation. So development of antibodies with prolonged therapy in calcitonin. Salmon calcitonin is available as a nasal spray, which is introduced for the purpose of once-per-day treatment in postmenopausal osteoporosis. Also for osteoporosis. So the side effect is nausea, add swelling, urticaria, and also intestinal cramping. The other one is estrogen, which is treated as a master. It helps to maintain the normal body absorption. It suppresses the proliferation and differentiation of osteoclast, increases osteoclast apoptosis. This is the production of several cytokines that are protein stimulants of osteoclast, and the most common is the interleukin 1, interleukin 6, and tumor necrotic factor. And you remember these cytokines again, they play a big role in acute inflammation. So the decrease of the production of LANCO and the increase the production of OPG reduces both osteogenesis in the body. So the postmenopausal or estrogen deficiency increases risk for osteoporosis. So estrogen replacement effective in the conservation of bone protection against osteoporotic fractures after menopause. The side effect is increased risk of heart disease and also breast cancer is found in using estrogen treatment. The other one is lavoxifenate, is a selective estrogen receptor modulator. Increases body absorption. It's given 60 milligrams once per day, and the side effect is hot flash, leg cramps, and thromboembolism. And it is contraindicated in pulmonary embolism and also in pregnancy and lactating mother. That is an example of of um, of an example of estrogen molecule. Then we have calcium. Calcium. Calcium is found in diet. There is a controversy about the role of calcium during the early years after menopause, when the primary basis of the bone loss is estrogen withdrawal. Patients who are unable or unwilling to increase calcium by this diet, that the beings around may source from many palatable like low-cost calcium preparations or calcium carbonate, which should be taken with use to facilitate distribution and absorption. So traditional dosing of calcium is 1,000 milligrams per day, and nearly the amount present in a quart of milk. Quart of milk is enough per day. Adult more than 50 years need 1,200 milligrams of calcium daily. So the other one now is parathyroid hormone preparations like pantotine, pantotine act as a parathyroid hormone, increases bone formation by stimulation of osteoblast, increases renal absorption of calcium, and the doses of the pantotine is given 20 milligrams once per day. Side effect, it can cause orthostatic hypotension and also can cause hypocalcemia. Contraindication is hypercalcemia and hypersensitivity. that is the end of this today's lecture about drugs used in food management. So thank you very much for listening to this lecture, and I think you'll be able to tackle questions related to this. Thank you very much.